The Rare Kidney Source podcast is for informational and educational purposes only and should not be used as medical advice. Please speak with your healthcare provider before making any treatment decisions. Before we get started, don't forget to subscribe and hit the notification bell so you never miss an episode. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts.
What if we told you someone had high blood pressure as a child, protein in their urine at 4 years old,
Where protein is not supposed to be.
visible blood in their urine in high school,
Not scary at all.
daily vomiting in college and not from partying too hard,
And after all of that, this person is still being told over and over again, you are fine. Yeah, right. What if the disease wasn't invisible, but instead just misunderstood?
That's what we're diving into today. Kidney diseases like C3G and primary IC-MPGN are conditions driven by the complement system. And let's break that down because, to be honest, that sounds like it's straight out of a science textbook.
It does. But here's the simplest way to think about it. If your immune system is your body's security system, the complement pathway is the alarm. It's always armed and quietly monitoring. It's supposed to go off when there's danger, and then go back to monitoring when the danger is gone. Short burst, problem solved, system resets. But in a complement-mediated kidney disease, the alarm doesn't shut off. It just keeps firing in overtime, even when there's no intruder. And over time, the constant alarm signal causes inflammation and damage in the kidney's filtering units. It's not that it doesn't work, it's that it works too much.
This is the story of what happens when the body's alarm system malfunctions, and how science is finally learning how to repair it. Welcome to the Rare Kidney Source. This episode of the Rare Kidney Source podcast is sponsored by Apellis Pharmaceuticals, where courageous science and compassion drive our commitment to the rare kidney community. We believe people living with C3G and primary IC-MPGN deserve connection, understanding, and a community built around their needs. That's why we created Rare Kidney Source, a destination and podcast featuring real patient voices, leading experts, and trusted conversations to help you navigate your health journey with confidence. We're here to help you stay informed and connected. Visit rarekidneyandyou.com today.
Before there was a diagnosis, there were years of warning signs.
Michelle Farley was only 4 years old when her body started whispering that something wasn't quite right.
Hi, I'm Michelle Farley. I was diagnosed with C3G in May of 2018, and I'm currently a PhD candidate. I had a lot of unexplained, undiagnosed symptoms starting at age 4. So I had protein in my urine and blood in my urine starting at age 4. I also had high blood pressure throughout my whole childhood, and all the doctors were like, oh, that's how it's always been for you. And then in high school, I had visible blood in my urine, and I also, from doing track, I was getting chest pains and was diagnosed with irregular heartbeats. And then they were looking into the blood in my urine. They did a kidney ultrasound and didn't find anything. So then next, they were prepping my mom for a bladder cancer diagnosis. They did a bladder biopsy and didn't find anything, and so it just stopped there. And then during college, I was throwing up all the time. I was getting migraines and headaches, and so I was diagnosed with stomach ulcers. I was also getting pain in my back, which they said was probably ovarian cysts.
Let's just pause there. Now, we're not saying that all of those things Michelle experienced were directly related to her C3G diagnosis, but high blood pressure as a child, protein in her blood and urine at 4.
My problems at 4 years old were directly related to who controlled the TV on Saturday mornings. I can't even imagine. And then being told that's just how it's always been for you, which is such a wild thing to say to a patient when you think about it. Your normal is abnormal.
Right? Especially when the alarm underneath it was already going off. Ultrasound, nothing. Biopsy, nothing. Ulcers, ovarian cysts. But you're too young.
On and on and on until it flat out couldn't be ignored.
And so it was just building. And then years later, when I went into my PhD program, the first year, I was tired of throwing up every day at this point. And so I went to the University Medical Center, and I was having a hypertensive or blood pressure episode, but they were like, "You're about to have like a heart attack or a stroke right now." And so that's when it really jump started to find the actual diagnosis. So, yeah, it was a long time of a lot of symptoms.
For many rare kidney patients, diagnosis doesn't begin with a test, it begins with a crisis. And that's where science enters the story.
To understand what's happening beneath Michelle's symptoms, we turn to Dr. Carla Nester, a physician scientist who has dedicated her career to understanding complement-mediated kidney disease.
Hello, my name is Carla Nester. I'm at the University of Iowa, and I'm a professor of internal medicine and pediatrics with a focus on complement-mediated kidney disease. C3 glomerulopathy and immune complex MPGN are, I'll say, the poster childs, if you will, of complement-mediated kidney disease. The data, animal models, etc., is absolutely excellent to support the fact that underlying this set of diseases is alternative pathway dysregulation. Now, that's the driving aspect of the disease, but I will say that they present like just usual glomerulonephridities very frequently. It's just that unfortunately, for a lot of patients involved, there's just a very rare driving force, and so that sometimes makes it very hard to figure out what's going on.
Okay, so let's translate that.
For our fellow non-science majors out there,
Your kidneys have millions of tiny filtering units called glomeruli, and their job is to clean your blood. Like a Roomba for your kidneys.
sure. In C3G and primary complex MPGN, part of the complement system becomes overactivated. Instead of constantly monitoring before activating and shutting back down, it remains on. Remember that alarm we talked about? In C3G, it doesn't shut off. It keeps signaling danger even when there's no intruder. It doesn't reset. At first, it may just seem like background noise. I mean, really annoying noise, distracting, uncomfortable noise.
Exactly. But over time, it causes damage. That's what chronic complement activation does inside the kidney. And because the outward symptoms present like more common kidney inflammation, doctors may treat it like something familiar, when the underlying driver is, in fact, rare. That gap between surface symptoms and root cause is where many patients live for years.
So I had diagnosis of stomach ulcer was a lot of the symptoms were attributed to. But after the blood pressure episode, I met with a nephrologist, and he said I was too young to have kidney disease, and that if I actually did have kidney disease, the blood pressure medicine at the dosage I was at wouldn't be working. And so I had to argue with him to get me a kidney ultrasound at that point. We did get one done, and the results said the morphology, and at the end it said consistent with chronic kidney disease. He came back and said, I have quotes that I had written down in my notebook here back in the day. And his quotes were that nothing bad shown on that ultrasound. Don't worry about the terminology. The kidneys really did look good, and it will disappear on its own. So I got a second opinion after that one, because at that point I had started researching what the blood work was showing. And that second nephrologist did order a biopsy. And I met with the nephrologist afterwards. And at that point, he diagnosed me with FSGS and said that the pathologists were still working on the samples at that point to try to determine the actual cause. And he said that there was 7 out of 8 filters in the biopsy that were like scarred or damaged. And he did mention C3 was low in my blood work, but normally that didn't relate to kidney disease. And he actually said at that time that no matter what it was, it wasn't worth treating at that point because of the amount of damage that was shown in the biopsy. When I did get the diagnosis, it was just uploaded onto my chart, and that's when I found out I had dense deposit disease, which is like a sector of C3G. And yeah, so that's how I was diagnosed, through my chart.
Finding out through my chart.
That part hits hard.
Your story's not terribly uncommon, unfortunately. I think that, again, because it presents like a usual glomerulonephritis, a lot of times physicians are downplaying the sheer seriousness of it, or just how much of an impact it could have on your life, thinking, oh, like in kids, it's post-infectious glomerulonephritis, it's going to go away. We just give it some time, it'll go away. I could definitely see those things being said to you, or hear those things being said to you. I will also say no one should ever find out about their C3G diagnosis via my chart. I mean, it should be a little bit more of extensive a discussion than that. But honestly, I've heard these stories, unfortunately, more times than I would like to admit that these things have happened.
We have now moved beyond the era of silencing the whole security system just to stop the noise. Now we can go straight to the alarm that's malfunctioning. The problem? Too many patients are still stuck trying to figure out why the alarm is going off in the first place.
Exactly. It used to be suppress the whole immune system and hope. Now, targeted therapies go straight to the faulty alarm.
I kept it a secret from everyone except from really close friends and immediate family. I even made like a separate social media account where I connected with people with chronic illness, rare diseases, kidney disease, and I made community there. And that's where I shared my information, got my information, and had that community, and met other people with C3G as well. I kept it from work so I wouldn't get overlooked for certain things. I don't really talk to many people about it openly. I was forced to once I was at the transplant point. I was forced to once I was at the transplant point where I was asking for a kidney. And so now I give updates every once in a while broadly, but on a day-to-day, I don't talk to people unless you're close to me.
It's a rare disease, and that can mean a rare diagnosis experience. Many physicians simply aren't familiar with all of the nuances, and that's why having your own understanding and being willing to ask questions really matters.
And in C3G and primary IC-MPGN, there isn't a single blood test that simply says the alarm system is malfunctioning.
I think that for a lot of physicians and for patients, the diagnosis of either C3G or immune complex MPGN, the slowness to get to the diagnosis very frequently is because it's so rare. I think the average physician just doesn't think that it's going to be this rare disease when they're first presenting. And then I think one of the things that we're actually challenged by is this: we don't have a lab test. It's not like you can go in and get a blood test, and when you get that answer for the blood test, it says, aha, you have C3G. There just isn't a simple blood test that you can do to actually get the diagnosis. And then maybe the third aspect of that is that even when you do get the biopsy, there are some confounders. There are other diseases that can masquerade like an immune complex MPGN biopsy or a C3G biopsy. So if you combine all three of those things, it can actually make it fairly difficult to actually make the diagnosis for the first time. At least historically, this has been the problem.
So there are three barriers. It's a rare condition, there's no simple lab confirmation, and even biopsies can resemble other diseases.
Historically, that's meant long diagnostic journeys and many misconceptions. But the good news? Patients today have more support. There are tools to help you understand the disease, track your questions, and advocate with confidence. One great place to start is rarekidneyandyou.com.
I think that one of the misconceptions is untreatable disease. You're stuck with it. You're going to have glomerulonephritis your whole life. There isn't anything we can do about it. We're just going to have to give you a whole bunch of steroids, etc. As of 2025, we should change that misconception completely. But I think it still will plague a few of our physicians just because they haven't had the opportunity to be exposed to the disease.
A lot of what patients are told today comes from an older era of treatment when doctors didn't have targeted tools.
And that's what shapes the narrative of being untreatable or hearing you just need steroids and let's wait and see.
When I was first diagnosed, the diagnosis was put up to my chart. And I started Googling, and I was in my PhD program, so I had access to journals. So I was reading articles, and I faxed over 4 pages of questions to that nephrologist. And that nephrologist responded, I'm a general nephrologist. You definitely need a specialist, which I think is very smart. And I think not a lot of patients get that type of honest reaction.
There's something powerful about a nephrologist saying, I'm a general nephrologist and you need a specialist.
Oh, absolutely. That is not a weakness. That is putting the needs of the patient first instead of just pushing them through the system.
So I went to Google, which was the worst place because it was very grim. And at that point, there wasn't a lot of information. And then I went to articles as well because I had that access through my PhD program. And yeah, I don't think a lot of patients have that access or resource for articles. So yeah, a lot of patients I know have Google. And then on a completely like different level, community-wise, I found the Iowa Patient Conference. So I went to that, I think like 4 months after I was diagnosed, which was like fantastic to get all that information. And then we have like a Facebook group so you can like confer with other patients with your disease. And yeah, so that was a great place to get information as well as community.
But Google can be absolutely terrifying.
Especially when the data you're reading is before proper guidelines even existed.
Right now, there are guidelines that have been published that help us understand what we need to do about it. But even more importantly, again, more recently, now we have targeted therapeutics that actually can go directly to what the underlying problem is. So these are all differences now in the way I would explain, that someone has rare disease. Back when a patient was being diagnosed, 10 years ago or something like that, it was a pretty dismal discussion because we said it's a rare disease. We don't know exactly what to do about it. We know that we can expose you to this number of agents, but we honestly don't know which one, if any one, is actually going to do you any good. So that's why I would go back to, one of the important things to get out of your physician is that yeah, you have to treat me. You have to you have to start me on a medication, but you need to stay with me and make sure that I've responded to it and that I am actually, getting better. So it can be very difficult. But I would separate it into 2 eras. We had, the pre-targeted therapeutic era, and now we have the post-targeted therapeutic era. So it remains to be seen if we can, paint a much brighter picture about receiving the diagnosis of this rare disease.
That right there, the pre-targeted therapy era versus the post-targeted therapy era. That is huge. For years, the approach was suppress the whole immune system and hope for the best, which is basically trying to shut down the entire security system because the alarm won't stop.
We understand the pathway and we have therapies designed to interrupt it. This is a completely different conversation than 10 years ago.
For instance, if you said to your doctor, okay, what are the choices of what's causing my disease? Give me 3, items on your differential diagnosis that could be causing my disease, and tell me how you're going to work through those. How are you going to rule out each one of them? It's not number 1 because, it's not number 2 because, we are left with number 3, etc. And if it turns out that C3G, or in this, dense deposit disease is the diagnosis, then I think after you get the diagnosis, the very next step needs to be asking your physician, so what are we going to do about it? What's your current approach? Are you going to use a guideline approach? Are you going to use, is there a local expert that we can chat with? Just get out of them what their approach to you is going to be, because it will then allow the patient will then be able to go back to either their resources, if there are ones that they have found reliable for them, or they will be able to go other places and confirm whether that approach is actually going to be useful, or is that the state of the art approach. And then I might finish up with, let's say you do all the things that, you've diagnosed me correctly. Now you've told me what you want to do to make me better. Then I want to know, how are you going to know I'm better? And if I'm not better, what are you going to do about it? So it's almost like, the story never ends. You need to keep going until you definitely are better. And, your physician should be, a partner with you in that. They should be constantly moving you towards whatever the better state is. They need to be moving you towards that.
Asking questions and being involved in your care isn't being difficult, it's being engaged. And the landscape for rare disease care should feel like collaboration, not dismissal. So the 3 things Dr. Carla suggested asking are:
what's on the differential diagnosis for what could be causing these issues? What's your current plan of approach? How are you going to know I'm better? And if I'm not better, what are you going to do about it? Barriers can turn diagnosis into years, but asking the right questions can help move you towards a better state of being.
And when we say better, we mean measurable improvement. Lab values stabilizing, protein in the urine decreasing, kidney function improving, symptoms resolving. Better should be defined clearly and agreed upon together.
I wish there's more on Google to understand. I think there is. There's a lot more available, and a lot more organizations focus on our rare disease. And I think that has to do with our patient community. I wish there was more mental health support. I think that is an overlooked aspect of rare disease and kidney disease in general, which is getting better, but definitely can be improved on. I also wish that I knew to have a healthy distrust of doctors. Um, Sorry to say it in front of a doctor, but I'm just wondering if we had second guessed earlier, how that prognosis could have been for my life. And just knowing that you know your body better than anyone else, and it's okay to come with curiosity, ask questions, get second or third opinions, in order to get the correct diagnosis. And then totally left field, I wish I knew how to navigate insurance. That is a big burden throughout my entire time. I currently just got a denial for the medicine I've been on for 10 months that's shown improvement. But because it's shown improvement, now I don't show that I have kidney disease, so they don't think I need it anymore. So it's just a fun time to work with appeals and argue with insurance.
Mental health support, insurance navigation, and permission to question authority are not side notes in rare disease, but instead they are survival skills.
And sometimes that includes getting a second opinion, not because you don't trust your doctor, but because rare conditions deserve rare expertise.
I became very educated throughout my time, so I basically have become my own doctor. But because we're at a point where there's more treatment and understanding, I am at a point where I don't have to be my own doctor a lot of the times, which is really nice. So I am almost 2 years post-transplant, and a little bit after the 1 year mark, I came, and normally I come with these like big binders, like questions, notebooks, like I have things memorized. And my doctor was asking me some questions. I was like, oh, I don't know. Let's check. And she's like, you don't know this stuff right now? Where are your binders? And I was like, I just like to live right now. And I'm at the point, and I think in our disease treatment and understanding, we're at that point where you can relax a little bit and be like, I don't have to be my own doctor. I can just live for a little bit. And that's a really nice stage to be at for a lot of patients. We're not like fighting anymore. Yeah.
I just like to live right now.
I mean, that's always the goal, right? Not constant alarm monitoring or living inside the lab values.
Yeah, and currently the stats without the targeted treatments, 50% of C3G patients lose their transplant. And with that, many patients aren't allowed the opportunity to get a transplant because transplant centers are nervous about their own stats because it is known to come back. And so to be at almost 2 years and 95 filtration rate, no signs of kidney disease, yeah, I think that just shows the success of the hard work of the patient community and the specialists at this point for the rare disease.
Historically, about 50% of C3G patients lost their transplants. But today, Michelle is nearly 2 years post-transplant, has a 95% filtration rate, and no signs of disease.
That's not luck, that's science. That's persistence. That's targeted repair of a malfunctioning alarm. That's turning off the alarm and shouting your security passcode.
Peaches!
And being heard.
And the E's are threes.
The road to diagnosis in rare kidney disease can be long, but awareness shortens it, collaboration strengthens it, and targeted science is redefining what's possible.
This is Rare Kidney Source, and we are just getting started. To learn more, resources and tools for patients are available at rarekidneyandyou.com.
The Rare Kidney Source podcast is produced by Bloodstream Media and made possible by Apellis Pharmaceuticals. If this conversation resonated with you, make sure you're subscribed and tap the notification bell so you don't miss what's coming next. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. Thanks for being part of the community.